I'm talking today with Professor Susie Nilsson, who is a Senior Research Scientist at the CSIRO here in Melbourne. You've written about the harvesting of stem cells and a new technique that hopefully makes things a bit easier for donors. Tell us a little bit about what happens now.
So essentially, stem cells are harvested from two different types of donors, and it depends whether they're going to be used in an allogeneic transplant or an autologous transplant. An allogeneic setting is where I'll give my stem cells to somebody else in a match situation. An autologous is where they're harvested from me to go back into me.
Right.
So currently, the protocol is slightly different for the two different types of transplants. For the allogeneic settings, the gold standard is the use of a single growth factor, GCSF.
Yep.
That has been proven to work for many years and is routinely used. However, there are some issues with using GCSF. You have to give multiple doses over multiple days.
Yep.
Even though it can be sent home with a patient and used in an outpatient procedure, obviously that's an inconvenience to the patient.
Yep.
In addition to that, not everybody reaches a certain number of stem cells within the blood after the end of that period, but because they then have to schedule in apheresis, which is the collection of your blood stem cells from the patient, there's a big cost and inconvenience to rescheduling the apheresis, so they usually will go ahead whether you've got to the right number of stem cells or not. And on top of that, not everybody responds, and there are side effects.
Right.
The big side effects are bone pain, and you can have situations of splenomegaly or a very enlarged spleen, or even there's been cases of splenic rupture. And this occurs because GCSF is not a specifically targeted growth factor.
Right.
It will influence your whole marrow. It causes a cytokine cascade. A whole plethora of things happen. Cells divide. Your bone is rapidly reabsorbed, which causes the bone pain because it activates your bone-eating cells or your osteoclasts. So it's not ideal. In the autologous setting, they use GCSF, and they have a molecule that's in the clinic at the moment, AMD 3100, which is an example of a small molecule that specifically targets an interaction in the bone marrow. And they add the AMD 3100 when they call a last-ditch attempt. So if I need to have my stem cells harvested, I haven't reached the level of stem cells in the blood that I need, they will give me the AMD 3100.
Right.
The benefits of the AMD 3100 is that it's a one injection and it works very rapidly, and they can do the apheresis a couple of hours later. The negative is that it's priced is very high, and therefore it's rarely used because it's not part of the PBS within Australia and patients can't afford it. Where we've come into this situation is we've been working at trying to understand how stem cells live in the microenvironment of the bone marrow, how that microenvironment regulates them, interacts with them, tells them when to divide and mature to give you all your cells that circulate in your blood, or when to sit there and be quiescent for need later on in life. And by understanding those interactions, we were able to identify a specific target for a molecule that we thought would allow us to make a new mobilization agent that would specifically and rapidly release stem cells of the desirable stem cells without the need for GCSF.
Cool.
So what we came up with, this small molecule that we've termed BOP, because it has a very long chemical name that I can't pronounce, and we've shown that you can give a single dose, and 1 hour later, your stem cells will have moved to the peripheral blood, and you can be harvested.
Cool.
On its own, it's not perfect, but if we combine it with the AMD 3100, or there are now generics of AMD 3100 coming out, because AMD 3100 comes off patent next year, so there's a large number of generics flooding the market, that the two of them together are as good as GCSF.
Without the side effects?
Well, they don't have the side effects because it's one single dose, so you don't end up with this whole cytokine cascade and this whole cell division and all the other side effects.
Fantastic.
So our hope is that we can take the use of two small targeted molecules into the clinic, an hour later, harvest, or 3 hours later, harvest, book in your apheresis, and use it in both an allogeneic and autologous setting. That's the ultimate goal. We hope that we will take it to clinical trial in the next 18 months. We're at the moment negotiating with a number of different companies to partner who are in the process or have already got the small molecules that target the other interaction in clinical trial. The nice thing is they target two different interactions, that's why the combination is better.
Yeah.
So the AMD 3100 doesn't work on its own either. So these companies are already doing their clinical trials with G.
Yeah.
So to be able to go away from using G would be a benefit.
Thanks for your time.
You're welcome.